10 key points about acute pancreatitis. Acute pancreatitis is a sudden inflammation of the pancreas. The pancreas is a gland located behind the stomach that is responsible for releasing digestive enzymes into the small intestine and hormones such as insulin and glucagon into the bloodstream. Acute pancreatitis occurs when these digestive enzymes become active inside the pancreas rather than in the small intestine, leading to self-digestion of the pancreas. The most common causes of acute pancreatitis include gallstones, alcohol abuse, and other less frequent conditions. Gallstones are small, hardened deposits that can block the bile duct, causing a backup of digestive enzymes and triggering pancreatitis. Chronic and heavy alcohol use is another major risk factor for developing acute pancreatitis. Other causes, though less common, may include high levels of calcium or triglycerides in the blood, certain medications, infections, abdominal trauma, and genetic disorders. Recognizing the symptoms of acute pancreatitis is essential. The primary symptom is sudden and severe abdominal pain, typically located in the upper abdomen and often radiating to the back. Patients may describe the pain as sharp, stabbing, or burning. Other accompanying symptoms can include nausea, vomiting, fever, a rapid heart rate, and abdominal tenderness or swelling. A thorough physical examination is critical in evaluating a patient with suspected acute pancreatitis. Physicians will palpate the abdomen to assess for tenderness, guarding, and rigidity. In some cases, they may look for specific signs such as Cullen's sign, a bluish discoloration around the navel, and Gray-Turner sign, a bluish discoloration on the sides of the abdomen. Although rare, these signs can indicate hemorrhagic pancreatitis. Laboratory tests are vital for confirming the diagnosis of acute pancreatitis. Elevated levels of the digestive enzymes amylase and lipase, particularly lipase, are strong indicators, with values often being 3 times the upper normal limit. A complete blood count can detect signs of infection or inflammation, while a metabolic panel assesses overall health and identifies potential complications by measuring electrolytes, kidney function, and liver function. Additionally, elevated blood glucose levels may indicate damage to the insulin-producing cells in the pancreas. Imaging studies are useful for confirming the diagnosis and assessing the severity of acute pancreatitis. Contrast-enhanced computed tomography is considered the gold standard for diagnosing acute pancreatitis, revealing inflammation, necrosis, and potential complications such as fluid collections or pseudocysts. Ultrasound imaging can also be beneficial, especially in identifying gallstones as a cause. Assessing the severity of acute pancreatitis early is essential for effective management. Several scoring systems can help predict the severity and mortality risk, including the Ranson criteria, which uses 11 clinical factors within the first 48 hours of admission, and the Acute Physiology and Chronic Health Evaluation 2 score, which evaluates physiological parameters. The Bedside Index for Severity and Acute Pancreatitis score is a simpler tool, using 5 readily available clinical parameters, while the Computed Tomography Severity Index, based on computed tomography findings, serves as a powerful predictor of morbidity and mortality. Initial management of acute pancreatitis focuses on supportive care, with aggressive fluid resuscitation being a key intervention. Restoring and maintaining fluid balance through intravenous fluids is crucial to prevent dehydration and preserve organ function. Pain management is another priority, typically requiring intravenous opioids to control the severe abdominal pain associated with the condition. Bowel rest, which involves withholding food and fluids to allow the pancreas to rest and reduce inflammation, may also be helpful. An early low-fat oral diet is potentially beneficial in patients with mild pancreatitis. Monitoring for complications is an integral part of managing acute pancreatitis. Common complications include pancreatic necrosis, where the death of pancreatic tissue increases the risk of infection, and pseudocyst formation, which results in fluid-filled sacs near the pancreas. Other possible complications include abscesses, sepsis, and multi-organ failure, which can be fatal. While antibiotics are not routinely used in all cases of acute pancreatitis, they may be necessary in specific situations. For instance, when a significant portion of the pancreas dies, a condition known as necrotizing pancreatitis, antibiotics are required to prevent or treat infection. Antibiotics are also indicated if there are signs of infection, such as fever or an elevated white blood cell count. It is important to note that up to 20% of individuals with acute pancreatitis develop infections outside the pancreas, such as bloodstream infections, pneumonia, or urinary tract infections, all of which are associated with an increased risk of death. Fluid collections around the pancreas or necrotic areas may also become infected, requiring the use of antibiotics. If infection is suspected, antibiotics should be started immediately while the source of infection is determined. If cultures are negative and no infection source is found, antibiotics should be discontinued. One study showed no significant difference in mortality or infection rates between those who received preventive antibiotics and those who did not. However, the trend in both cases favored the use of prophylactic antibiotics. Current guidelines recommend using preventive antibiotics only for patients with necrosis involving more than 30% of the pancreas, while routine prophylaxis is suggested for patients with infections outside the pancreas, but not for those with severe acute pancreatitis or sterile necrosis. Finally, it is important to note that the use of probiotic supplements for preventing infectious complications in acute pancreatitis is not recommended, as studies have shown that probiotics are associated with an increased risk of death in these patients.
Question number 1. Which of the following scoring systems is used to assess the severity of acute pancreatitis? The correct answer is B. The Ranson criteria are a clinical prediction rule used to assess the severity and mortality risk of acute pancreatitis, involving 11 prognostic signs evaluated at admission and within 48 hours. A score of 3 or more indicates severe acute pancreatitis, correlating with higher mortality rates and potential complications. Question number 2. Which of the following is not a risk factor for developing acute pancreatitis? The correct answer is B. Common risk factors for developing acute pancreatitis include alcohol abuse, gallstones, and high triglyceride levels. Question number 3. Which clinical sign, characterized by bluish discoloration around the navel, may indicate hemorrhagic pancreatitis? The correct answer is B. Cullen sign is a clinical finding characterized by superficial edema and bruising in the subcutaneous fatty tissue around the umbilicus, often indicating intra-abdominal or retroperitoneal hemorrhage, most commonly associated with acute hemorrhagic pancreatitis.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.